changes that occur over the period using some device. During surgery, when a patient is under anesthesia, this monitoring aids to know when to make a therapeutic intervention and to guide the assessment of interventions. The current standards of anesthesia monitoring, which were published by the ASA, last updated in 2010 and reaffirmed in 2021, specify that during anesthesia, oxygenation, ventilation, circulation, and temperature shall be continuously measured. The adverse neurological outcomes following several surgical interventions persist as a problem. So, in addition to these physiological monitoring that were set by ASA, comprehensive brain function monitoring may result in a better perioperative outcome. So, the neurological outcome, neurological monitoring is broadly classified based on the parameters that it monitors. Electrophysiological monitoring are EEG and evoked potentials. Then intracranial hemodynamics can be monitored by cerebral blood flow monitoring using Transcranial Doppler or ICP monitoring. Then metabolism can be monitored by seeing at the cerebral oxygenation using either the cerebral oximetry or jugular venous oximetry. And the intracranial biochemistry can be monitored either by looking at the neuronal biomarkers or by cerebral microdialset. There are a few requirements for a nervous system monitor. They being, changes in monitored parameters should reflect changes in the function or the blood supply of the part of the nervous system that is at risk during surgery. The monitor should be used continuously if possible, particularly during periods of risk. Then the number of other factors which may affect the monitored parameters should be minimal. And there should be some possibility of intervention to correct damage which is detected by these monitors during the surgery. There is another classification that is of these monitors based on whether they monitor function or whether they monitor blood supply. Monitors of function being electroencephalogram, evoked potentials, awake examination, and monitors of blood flow being transcranial Doppler, jugular venous oxygen saturation, and cerebral oximetry. So the wake-up test. It is an intermittent neurological monitoring that is used to test neurological function following a reversible surgical manipulation, which has a potential to cause neurological damage. Most commonly used after distraction of the spinal column during surgery for correction of kyphoscoliosis. It has been considered as gold standard since many years during the kyphoscoliosis surgeries, but its sensitivity is open to question. It is due to two reasons. First, when should we apply this test? It is the appropriate time is not clear. And second being, the test is applied only intermittently during most of the operation, and the nervous system function is unknown. And spinal cord and brain both have white matter and gray matter. We know that. And this gray matter, it has higher metabolic demand for oxygen, and it will stop functioning within seconds after a complete interruption in blood supply. Whereas the white matter, it consumes much less oxygen, continues to function for many minutes after a complete interruption. So this wake-up test, when it is applied immediately after a spinal column distraction, may fail to detect loss of blood flow to white matter pathways in mid-thoracic spinal cord. This mid-thoracic spinal cord surgery, that is the area which is at highest risk for ischemia during surgeries. But despite these shortcomings, results of the wake-up test seem to correlate well with the neurological outcome. Coming to the electroencephalogram. The EEG is a surface recording of summation of both excitatory and inhibitory postsynaptic potentials that are spontaneously generated by the pyramidal cells in cerebral cortical gray matter. The signals are very small, and each recording electrode records information both directly beneath the electrode and from the deeper tissues, which is from which the information volume is conducted. Monitoring the EEG is usually directed towards one or more of the following four perioperative uses. First one is it helps in identifying inadequate blood flow to the cerebral cortex, which can be caused either by a surgically induced or anesthetic induced reduction in blood flow. Second, it can be used as a guide and as in anesthetic induced reduction of cerebral metabolism, either in anticipation of loss in cerebral blood flow or in the treatment of high ICP. Third, the EEG may be used to predict neurological outcome after a brain insult. Finally, the EEG may be used to gauge the depth of hypnotic state of the patient under general anesthesia. The raw EEG is very difficult to read, and finding changes in the raw EEG and thereby making assumptions is really difficult. But by using high-speed computerized EEG analysis and statistical methods, EEG patterns in the continuum from awake to deeply anesthetized are becoming much better understood. So, concepts of basic unprocessed EEG. The EEG is produced by, as already said, it is a summation of excitatory and inhibitory postsynaptic potentials that are produced in the cortical gray matter. Because the EEG signal is generated only by postsynaptic potentials, it is much less, smaller than the action potentials recorded over nerves or from heart. Extreme care must be taken when placing these electrodes to ensure proper placement and excellent contact with the skin to avoid significant signal loss. Then these electrodes generally are placed according to a mapping system that relates surface head anatomy to the underlying cortical regions. So this placement pattern is called a montage. Use of standard recording montage is useful because it permits anatomic localization of signals produced by the brain and allows development of normative EEG patterns, and it helps us in comparing the EEG recordings which are made at different times. Standard EEG map is called the 10 to 20 system for EEG electrode. The numbers 10 and 20 refer to the fact that the distances between adjacent electrodes are either 10% or 20% of the total front to back or right to left distance of the skull. So this system is a symmetric array of scalp electrodes placed systematically based on the distance from nascium to the inion and from the pretracheal bony indentations associated with both temporomandibular joint. Now, the nascium means the point between forehead and the nose, and inion is the lowest point of the skull from the back of the head and is normally indicated by a prominent bump. So this is the montage, 10 to 20 system of electrode placement. So as we can see, F is frontal, T temporal, P parietal, and O is occipital. The left-sided electrodes have been given odd number subscripts, and the right-sided electrodes have an even number subscripts. As we move from the center to as we move away from the center, the number of the subscript increases, and the electrodes that have been placed in the midline have a Z subscript. The EEG signal is described using three basic parameters: amplitude, frequency, and time. Amplitude is the size or voltage of the recorded signal and ranges commonly from 5 to 500 microvolts. In ECG, the signal is 1 to 2 millivolts. Because neurons are irreversibly lost during the normal aging process, EEG amplitude decreases with age. This is important for us. Then frequency can be thought of simply as the number of times per second the signal oscillates or crosses the zero voltage line. Then the third parameter is time, which is the duration of sampling of the signal. It can be continuous or it can be a sampling epoch, as is used in the processed EEG. The normal EEG. The usual base frequency in an awake patient is beta range, which is more than 13 Hz. This high frequency and usually the low amplitude signal is common from an alert, attentive brain and may be recorded from all regions. With eye closure, higher amplitude signals in the alpha frequency range, which is 8 to 13 Hz, is seen best in the occipital region. This eyes closed resting pattern is a baseline awake pattern that is used when anesthetic effects on the EEG are described. When events that lead the brain to produce higher frequencies and larger amplitudes occur, the EEG is described as activated. And conversely, when slower frequencies are produced, such as theta, which is 4 to 7 hertz, and delta, which is less than 4 hertz, the EEG is said to be depressed. The EEG during natural sleep may contain all of these frequencies at various times. Slower frequencies occur during deep natural sleep with sleep spindles, but during light sleep or REM sleep, the EEG becomes activated and the eye muscle EMG appears from the EEG. So here we can see in the center, there are sleep spindles, and there is a normal sleep pattern. Coming to the abnormal EEG. General characteristics of the abnormal EEG include asymmetry with respect to either frequency or amplitude or both, recorded from corresponding electrodes on each hemisphere, and patterns of amplitude and frequency that are unpredictable or unexpected in the normal recording. These abnormal patterns reflect either anatomic or metabolic alterations in the underlying brain. Regional asymmetry also can be seen with tumors, epilepsy, cerebral ischemia, or infarction. What happens in an epilepsy is there are high voltage spikes and slow waves, whereas in cerebral ischemia, it manifests in two waves. Initially, there is EEG slowing with preservation of voltage, but as the ischemia becomes more severe, there is further slowing and loss of voltage. Symmetric abnormalities of the signal. Identifying pathologic abnormal patterns in the global EEG signal is very important, although sometimes quite difficult. So many of the normal global pattern changes produced by anesthetic drug are also similar to the pathologic patterns that are produced by either ischemia or hypoxemia. And control of anesthetic technique is very important when the EEG is being used for clinical monitoring of the nervous system. So we have used a term called epoch. What is an epoch? EEG processing for intraoperative monitoring is typically based on power analysis of a segment of raw EEG, and that is referred to as an epoch. Power analysis uses Fourier transformation to convert the digitized raw EEG signal into component sine waves of identifiable frequency and amplitude. The raw EEG, which is a plot of voltage versus time, is now converted to a plot of frequency and amplitude versus time. And so an important consideration in the process EEG is time. In raw EEG, it is continuous in real time, and processed EEG samples data over a given time period, which is an epoch, processes the data, then displays the information in various formats. A longer epoch may produce less epoch to epoch variability, allows more precise description of frequency and power. However, it has a backlog, that is, a longer epoch increases the delay before new information is processed and displayed, reducing the amount and timeliness of information that is available for clinical decision making. Currently available, commercially available devices have used 2-second epoch lengths, updated at varying user-selected intervals. With better and faster computers, continuous monitoring of a 2-second epochs and now even longer epochs is also possible. Coming to the processed EEG, a raw EEG signal is digitized, processed, and then graphically displayed for easy interpretation. The processed EEG is normally, these monitors are normally used for us in identifying the depth of anesthesia in intraoperative patients. So, with a briefly I'm saying about them. So, the processed EEG types are Bispectral Index, Entropy, Patient State Index, and Narcotrend. Bispectral Index is an empirically derived scale that was proposed in 1994 by the Aspect Medical Systems. So use of BIS monitor has been proposed as a way to prevent intraoperative awareness, which is defined as the patient having explicit recall of events that transpired during the time that he or she was under general anesthesia. The algorithm processes the EEG in near real time, computes an index value between 0 and 100, and that indicates the patient's anesthetic state. A value of 100 corresponds to being completely awake, whereas 0 corresponds to a profound state of coma or unconsciousness that is reflected by an isoelectric or flat EEG. So this is this index from 0 to 100. 0 is flatline EEG, 20 is burst suppression, 40 indicates the hypnotic state, 60 is reversible under general anesthesia. So there is low probability of explicit recall under when the range is around 60, and patient is unresponsive to verbal statements. 80, this is seen in light or moderate sedation, and the patient may respond to loud commands or mild prodding or shaking. When it is 100, the patient is awake and responds to normal voice. Coming to entropy. Entropy means a degree of randomization. But as the consciousness decreases, EEG becomes less random and more regular, which means there is a decrease in entropy. The entropy monitor has two components, state entropy and response entropy. State entropy corresponds to cortical activity, and it tracks EEG power changes in the range of 0.8 to 32 Hz frequency band. Response entropy describes the EMG activity, and it tracks the EEG power changes in 0.8 to 47 Hz frequency band. So when a patient is profoundly unconscious, the first decrease is entropy than the state entropy. Values for from 0 to 91 and correlate well with the consciousness level. Patient state index, it records EEG activity from anterior and posterior scalp side, and similar to BIS index, its values range from 0 to 100, indicating a deep plane of anesthesia when it is 0, and fully conscious patient when the number indicates 100. Narcotrend, it classifies EEG into 14 distinct stages of anesthesia from stage A, which is awake, to stage F, which is isoelectric. Like BIS and PSI, its values range from 0 to 100. Compared to BIS, PSI and narcotrend are less commonly used. Then comes the evoked potential monitoring. The neural structures in the cortex and subcortex are periodically stimulated to produce electrical signals, and response is recorded from the surface electrodes. Random background electrical activity is removed. Average evoked potential data is displaced as latency. Latency is time from stimulation and amplitude of the peaks generated. Based on latency, electrical potentials are classified into three categories: short latency potentials, intermediate latency potentials, and long latency potentials. Short being 10 to 40 milliseconds, intermediate being potentials that occur within 20 to 120 milliseconds, and long being the potentials which occur above 120 milliseconds. Somatosensory evoked potentials or SSCPs, they are recorded after electrical stimulation of a peripheral mixed nerve using needles or surface gel electrodes. A square wave stimulus, which lasts for 50 to 250 microseconds, is delivered to the peripheral nerve, and the intensity is adjusted to produce a minimal muscle contraction. The common sites of stimulation include median nerve at the wrist, common peroneal nerve at the knee, and posterior tibial nerve at the ankle. Upper extremity evoked potentials are likely conducted rostally in the spinal cord through dorsal column pathways, and lower extremity SSCPs are conducted by lateral funiculus. So stimulation of the posterior tibial nerve or common peroneal nerve at or higher than motor threshold activates group 1 fibers. They synapse and travel rostrally through the dorsal spinocerebellar tract. After synapsing in nucleus Z at the spinomedullary junction, the pathways cross and project onto the ventral posterolateral thalamic nucleus. The lower extremity cells are conducted in all quadrants of the spinal cord, but primarily in the dorsal lateral funiculus. This is important because it is supplied primarily by the anterior spinal artery, and manipulations during scoliosis correction may secondarily compress or distort the radicular blood supply to anterior spinal cord, and it should cause changes in the SSEPs in the event blood supply is decreased to critical levels. The decrease in SSEP amplitudes, either more than 50% or increase in latency of more than 10% from baseline, is an alarming indicator of intraoperative neural damage. SSEPs help in detection of cortical ischemia, and they become abnormal when cerebral blood flow decreases to 20 ml per minute per 100 gram and is lost when it further reduces to 15 to 18 ml per minute per 100 grams. SSEPs also help in mapping sensory strip on the cerebral cortex. So this is a photo of SSEPs during aneurysm clipping. So there we can see an arrow which corresponds to the responses that are generated by the cortex at risk after the placement of retractors. So we can see there is decrease in amplitude after the placement of retractors, and there is increase in latency. Coming to the brainstem evoked auditory evoked potentials, they assess the auditory apparatus. The following application of rapid loud clicks to the external auditory meatus, recordings are obtained from scalp electrodes placed near the ear and cortex. Normal brainstem auditory response trace is labeled as 1 through 7, corresponding to the area of brainstem stimulated from 8th cranial nerve till the auditory radiation. So these are useful in surgeries involving CP angle, floor of 4th ventricle, and regions near 5th, 7th, and 8th cranial nerves. So more than 50% decrease in amplitude or more than 1 millisecond prolongation of the 1 to 5 negative latency waves and permanent loss of wave 5 are criteria for intraoperative nerve damage and subsequently postoperative hearing loss. Coming to the visual evoked potentials, VEPs are recorded after monoocular stimulation with recording electrodes over the occipital, parietal, and central scalp. What is done here is the retina is stimulated with a flash using light emitting diodes embedded in either soft plastic goggles through closed eyelids or as needed via contact lenses with built-in light emitting diodes. Then VEPs are cortical cells which vary with the type of stimulus, part of the retina stimulated, and degree of pupil dilation, and also patient's attention level. They are helpful in surgeries of pituitary, craniopharyngioma, and near the optic nerve. They assess the visual pathway from optic nerve to the visual cortex in occipital cortex. A bilateral response from either eye obscures the focal changes, and VEPs are sensitive to anesthetic agents. Next is motor evoked potentials. They are generated most commonly by the application of transcranial train of electrical stimuli, and responses are recorded at various points along the spinal column, peripheral nerve, and innervated muscle. Motor cortex is stimulated by electrical stimuli of 5 to 7 pulses with a high frequency of more than 200 Hz, and less commonly by magnetic stimulus using scalp electrodes. MEPs assess the functionality of descending cortical spinal tract, that is internal capsule, brainstem, spinal cord, peripheral nerve, and muscle. The criteria that is used to detect intraoperative neural damage are either absence of MEP or a decrease in amplitude of more than 70%, increase in stimulation threshold, or failure of signal amplitude to return to baseline. Direct cortical MEPs can map motor cortex, brainstem, motor nuclei, and spinal cord motor pathways. So MEPs of muscles innervated by motor cranial nerves such as facial nerve and recurrent laryngeal nerve are used when these nerves are at risk. And this is the corticobulbar response that is assessed. And anesthesia and evoked potentials. EPs are highly vulnerable to inhalational agents, especially when MAC is above 0.5. So when we are assessing the evoked potential, TIVA along with opioids is preferred. Maintenance of constant depth of anesthesia to interpret changes is must. We should strictly avoid hypoxia, hypercarbia, hypothermia, and hypoglycemia, as the decrease as the changes in evoked potentials due to these factors cannot be differentiated from changes that are caused due to damage to either neural damage or hypoxia. BAEPs are most resistant and VEPs are most susceptible to anesthetic agents. MEPs are better recorded in absence of muscle relaxant, and if muscle relaxant is at all used, then trainer for response during NMB monitoring should be maintained between 2 to 4 twitch counter. These are the guidelines for choosing anesthetic techniques during procedures in which sensory evoked responses are monitored. IV drugs have significantly less effect than equipotent doses of inhaled anesthetics. Combination drugs produce additive effects, and subcortical cells are very resistant to the effects of anesthetic drugs. So, if subcortical responses are providing sufficient information for the surgical procedure, then anesthetic technique is not important and effects on cortically recorded responses may be ignored. Into the cranial nerve monitoring, small size, circuitous scores, and delicate epineuria make cranial nerves highly susceptible to injury during intracranial and extracranial head and neck procedures. The cranial nerve function can be monitored by nerve conduction studies, EMGs, and EPs. All cranial nerves with a motor component can be monitored using EMG from respectively innervated muscles. Optic and auditory nerves are monitored using either visually evoked potentials or brainstem auditory evoked potentials, respectively. The most commonly monitored nerve is the facial nerve using ipsilateral orbicularis oculi or the orbicularis orisum / Vanoma surgeries. Coming to the EMG, the ability of a nerve to produce a response in the innervated muscle is used to assess the health of a cranial or peripheral nerve, that is electrodes or needle electrodes, which are placed directly in the breast if recordings are made from needles within the muscle itself. Surface electrodes and to a lesser extent subdermal needle electrodes may completely miss the neurotonic discharges that indicate damaged nerve. EMG monitoring can be either active or passive. During active monitoring, a cranial or peripheral nerve is stimulated electrically and the evoked EMG response from the muscle is recorded. During passive monitoring, there is continuous recording of all generated response from the innervated muscle groups. Nerve function also may be assessed by noting the intensity of nerve stimulus that is needed to evoke a muscle response and by the morphology of the compound muscle action potential. So here we can see facial nerve monitoring and typical responses that are seen during surgery. The electrodes are placed either in the orbicularis oculi or the orbicularis oris muscle. So 3 types of discharges are seen here. Popcorn discharges, which are produced by simple benign contact with the monitored nerve. Then we can see the response strain, which are produced when there is more significant nerve irritation. Then the neurotonic discharge, which are produced by significant nerve irritation or damage or both. So cerebral blood flow monitoring. For maintenance of anatomical and functional integrity of the human brain, 50 ml per 100 gram per minute of cerebral blood flow is essential. When this decreases to less than 15 ml per 100 gram per minute, there is failure of energy pumps and hence ischemia occurs. The brain pathology can disturb cerebral blood flow, which is further affected by the action of anesthetic agents. There are non-invasive methods to monitor global blood flow, one being intravascular tracer compound monitoring, that is the direct measurement of cerebral blood flow by determining the kinetics of wash in and wash out of an inert tracer compound. This is a method that was originally described by Kepi and Schmidt, and the most widely used measurement technique involves administration of radioactive isotope of xenon 133, and that is followed by measurement of radioactivity washout with gamma detectors placed over specific areas of the brain. The limitations being it provides only a snapshot of cerebral blood flow in time instead of continuous assessment of flow over time. And second, and most importantly, there is exposure of the patient to radioactive compounds. Into the transcranial Doppler, Aslev in 1992 introduced a non-invasive Doppler ultrasonographic study of intracranial cerebral arteries. So, PCD ultrasound offers real-time information of cerebral blood flow velocity and indirectly cerebral blood flow, provided the angle of insulation and the diameter of the insulated vessel remain constant. Recently, an ultrasonic perivascular flow probe has been developed for direct intraoperative cerebral blood flow, and it is based on Doppler principle. The ultrasound waves emitted from the transducer probe of 2 to 2.5 megahertz pass through thin skull bone, and that is the acoustic window. Acoustic window can be transtemporal, transorbital, submandibular, or occipital. And these waves are reflected by moving erythrocytes in a cerebral artery. When these sound waves are reflected off the red blood cells back towards the PCD probe, the velocity of the reflected sound waves is changed because the blood cells themselves are in motion either towards or away from the probe. This phenomenon is called as Doppler shift and is directly related to the flow velocity and flow direction of the blood cells. Lingard ratio is an important concept. It is the mean velocity of middle cerebral artery to the mean velocity of the inner carotid artery. It is important for differentiating hyperemia from true vasospasm on PCT study. It also helps us in grading the severity of vasospasm as mild, moderate, and severe. So, Lingard ratio of more than 6 indicates severe vasospasm, 4.5 to 6 moderate vasospasm, and 3 to 4.5 indicates mild vasospasm. The difference in the frequency of emitted and reflected waves is known as the Doppler shift effect, and it is proportional to the cerebral blood flow velocity. And these are a few. These help us in identifying it. Coming to the jugular bulb venous oxygen saturation, is the degree of oxygen extraction by an organ can be monitored by following the oxygen saturation of the mixed venous blood that drains that organ. In the case of brain, jugular bulb venous oxygen saturation (SGVO2) is believed to measure the degree of oxygen extraction by the brain and to represent the balance between cerebral oxygen supply and demand. To monitor SGVO2, a fiber optic catheter is placed in a retrograde fashion into the jugular bulb through the internal jugular vein under fluoroscopic guidance. Tip of the catheter is positioned above the lower border of C1 vertebrae and just medial to the mastoid process. Correct tip placement is crucial to minimize admission of extracranial venous blood. So normal SGVO2 is 55 to 75%. Less than 50% indicates critical low oxygen level with the onset of anaerobic metabolism and increased risk of brain ischemia. More than 75% indicates hyperperfusion or decreased metabolic demand of the brain. Limitations being difficult insertion in difficult anatomy patients, infection and thromboembolic phenomenon risk, limited role in focal injury as this gives global oxygen saturation, oxygenation status. When coming to the cerebral oxygen supply demand balance or cerebral oximetry. This is a non-invasive assessment of adequacy of cerebral blood flow by using a device that utilizes the principles of near-infrared spectroscopy. The probe is usually placed on the skin overlying the frontopolar portion of the cerebral cortex. Wherever the cerebral blood flow falls, there is increased oxygen extraction from the blood, and the cerebral venous oxygen saturation falls. So this is the same funda that is used in SJVO2 monitoring also. So this monitor works on the principles that near-infrared light penetrates the skull, and during transmission through or reflection from brain tissue, it undergoes changes in intensity that are proportional to the relative concentrations of oxy and reduced hemoglobin in the tissue beneath. The device has been used to predict occurrence of neurological deficit following carotid endarterectomy. It calculates cerebral oxygenation using the combination of two laws, Beer-Lambert law. The Beer law being intensity of the transmitted light decreases exponentially as the concentration of substance increases, and Lambert law states intensity of transmitted light decreases exponentially as the distance traveled by the light through the substance increases. The normal values are 60 to 80. Intervention trigger is less than 50 or 20%, less than or more than 20% change from baseline. Limitations mean it is a regional measurement, and there could be electrosurgical interference and inability to identify the cause of desaturation. This is a schematic of a regional oximeter sensor. So there are emitters or LEDs. Then we can see this is a dual detector oxygen sensor. So there are two photodetectors. One is a shallow detector and another is a deep detector. So the shallow detector is placed near to the LED, and as we can see, it is receiving the signal from superficial tissues. The deep detectors, they receive LED, the signal from the LED from the deeper tissues as well as from the superficial tissues. The deep tissue oxygenation can therefore be calculated by subtracting the effects of shallow tissue from deep tissue by manipulating signals that are received at the deep and shallow detectors. There are monitors for tissue level blood flow also by the thermal diffusion cerebral blood flow monitoring or tissue partial pressure of oxygen monitoring. Coming to the intracranial biochemistry, there are neurological biomarkers like S100B, which is released by glial cells into the CSF. It reaches a systemic circulation if blood-brain barrier is injured. Then neuron-specific kinolase, tau proteins, glial fibrillary acid protein, and metalloproteinase 9. Higher levels of these is associated with delirium, cognitive dysfunction, systemic hypotension, and cerebral desaturation. When reduction in the levels of CSF caspase-3 indicates that there is slowing of neuronal apoptosis in neural regeneration. And coming to the cerebral microdialysis, it helps in guiding individualized intensive care therapy, mainly after traumatic brain injury or aneurysmal SAH. So this cannot be used intraoperatively. It is an ICU neuromonitor. It allows measurement of metabolite concentration in extracellular space by passive diffusion principle using a semi-permeable membrane. The semi-permeable membrane allows small molecules to pass through it, such as glucose, lactate, pyruvate, glycerol, and ATP. So these are the current practices of neurological monitoring, different surgeries, and the monitors that are used during those surgeries. So in summary, regardless of the type of intraoperative neurological monitor, several principles must be observed for neurological monitoring to provide potential benefit to the patient. Firstly, the pathway at risk during surgical procedure must be amenable to monitoring. Second, if evidence of injury to the pathway is detected, some intervention must be possible. If changes in the neurological monitor are detected and there is no intervention that is possible. Although the monitor may be of prognostic value, it does not have the potential to provide direct benefit to the patient from early detection of impending neurological injury. And thirdly, the monitor must provide reliable and reproducible data. And if the data have a high degree of variability in the absence of clinical intervention, then their utility for detecting clinically significant events is limited. Hello? Hello?
Yeah, Chaitanya.
No, sir.
Nice class. Yeah, now the floor is open. Any questions, inputs?
చాలా డెప్త్ ఉంది శ్రీకాంత్ ఇందులో. నైస్ క్లాస్ అంటే ఎట్లా చాలా డెప్త్ ఉంది. అంటే రేడియాలజిస్ట్ బెటర్ ఆఫ్ అయిపోయిన తర్వాత ఇంకా డెప్త్ పెరిగిపోయినట్టుంది. అంటే మైక్రో డయాలసిస్ ఆఫ్ బ్రెయిన్ కూడా వెళ్ళిపోయింది కదా. అవేం చేయరా
సార్?
ఇంట్రాప్ టీసీడీలు కంటిన్యూస్ టీసీడీలు ఏం లేవా?
ఇంట్రాప్ కంటిన్యూస్ గానే చేయొచ్చు, ఇంటర్మిటెంట్ గానే చేయొచ్చు సార్. బట్ ఇంటర్మిటెంట్ ఇస్ మోర్ ప్రిఫర్డ్. ఇంటర్మిటెంట్ టీసీడీ ఇస్ మోర్ ప్రిఫర్డ్.
ఇంటర్మిటెంట్ టీసీడీ
సార్, బోత్ కెన్ బి డన్, బట్ ఇంటర్మిటెంట్ ఇస్ మోర్ ప్రిఫర్డ్.
ఇప్పుడు ఎస్ఎస్సిపి అవి చెప్పావు కదా, నేను కొంచెం ముందు స్టార్టింగ్ లో జాయిన్ అయ్యాను
సార్.
అందులో మామూలుగా బెడ్ సైడ్ ఈజీ ఎస్ఎస్సిపి కాకుండా ఇంకేం ఎక్కువ ఇంపార్టెంట్ ఇంట్రా ఓటీలో మానిటరింగ్ లో?
ఇవోక్డ్ పొటెన్షియల్స్ సార్.
అదే ఎస్ఎస్సిపి అంటే అదే కదా?
యా. Evoked potentials are important, mostly done, sir. Then cerebral oximetry can also be done.
అది ఎక్కడ అవుతుంది నీకు తెలిసి? నాకు తెలియదు. సెరిబ్రల్ ఆక్సిమెట్రీ ఎక్కడ చేస్తున్నారు?
అంటే ఏ సర్జరీస్ లో చేస్తారని అడుగుతున్నారా?
కాదు, వైజాగ్ లో ఎక్కడ?
అది నాకు ఐడియా లేదు సార్.
అంటే ఇక్కడ ఎక్కడ ఏదైనా సెంటర్ లో చేస్తారా? అది నీకు తెలుసా? కూడా సత్సాయిలో చూసాను నేను. సత్సాయి న్యూరోలో నేను ఇవన్నీ చూసాను, న్యూరో మానిటరింగ్ అన్ని. I wanted to witness and I was there for OT for 1 or 2 days to learn it. But నేను సెల్ఫ్ ఆక్సిమెట్రీ చూడలేదు, నాకు ఐడియా లేదు. మొన్న ఎవరు నన్ను అడిగారు
కార్డియాక్ కేసెస్ యూజ్ చేసేటప్పుడు, కార్డియాక్ కేసెస్ లో
చేసేవాళ్ళు చేస్తారు మామూలుగా. ట్రాన్స్ప్లాంట్ అప్పుడు క్యాథెటర్ ప్లేస్మెంట్ ఊరికి వీడియో ఎక్కడో చూసినట్టు కూడా తప్ప విచ్ సెంటర్స్ ఇన్ ఇండియా డస్ నాకు ఐడియా లేదు. శ్రీకాంత్, ఒకసారి చైతన్య, వంశీ వాళ్ళిద్దరిని పట్టుకొని న్యూ కపుల్స్ ఏదో చిన్న పార్టీ పెట్టించి తొందరగా.
ఓకే సార్, ష్యూర్. పార్టీ అంటే ముందుంటాను సార్.
చైతన్య ముందుంటాను కానీ మధ్యలో ఉండట్లేదు, వెనక్కి వెళ్ళిపోతుంది.
సార్ నేను మీకు టైం చెప్పండి, డేట్ చెప్పండి అని చెప్తున్నాను. డేట్ చెప్పండి.
మీ స్టూడెంట్ చెప్పాలమ్మా, నేను కాదు.
బేసిక్ గా అందరికీ కుదిరే డేట్
మాట్లాడకుండా మీ స్టూడెంట్ కి మాటలు రాకుండా చేసింది మీరు.
అమ్మ బాబోయ్, చాలా పెద్ద మాట అనేసారు సార్. ఇక్కడ ఓంకార్ సార్ అండ్ అనురాధ మేడం వీళ్ళిద్దరూ అయితే దే కెన్ కరెక్ట్లీ సే. అసలు అనురాధ మేడం వాళ్ళ ముద్దులు కొడుకు, సో అనురాధ మేడం చెప్పాలి.
మరి అంతే కదా. తొందరగా చేయండి.
Good morning. I have 2 questions. So what is penumbra and what is pulsatility index?
సార్ రమణ ప్రసాద్ సార్ మళ్ళీ చెప్పరా క్వశ్చన్ ఏంటో నాకు అర్థం అవ్వలేదు, బట్ ఆన్సర్ కూడా మీరే చెప్పండి వాళ్ళు ఎవరు చెప్పకపోతే.
Penumbra, first question, penumbra. Second, pulsatility index in transcranial Doppler.
నాకు తెలిసి పెనుంబ్రా అంటే మనకు స్ట్రోక్ వచ్చినప్పుడు ఆ వచ్చే ఏరియాను బిఫోర్ ఇట్ కమ్ బ్యాక్స్ టు నార్మల్ సెకండరీ డ్యామేజ్ అవ్వకుండా మనం గిన కరెక్ట్ సపోర్ట్ ఇస్తే బ్రెయిన్ కి ఆర్ ఈ థ్రాంబులైజ్ చేస్తే అదంతా మళ్ళీ వెనక్కి వచ్చే ఛాన్సెస్ ఉంది. సో దట్ ఈస్ నార్మల్లీ సీన్ విత్ ఫస్ట్ 3.5 hours నుంచి 6 hours ఎక్స్టెండ్ చేశారు కదా, సో దాన్ని పెనుంబ్రా అంటారా అనుకుంటున్నాను. ఆమె రైట్ సార్?
Yes, sir. The tissue surrounding the centralized necrotic tissue, which is potentially survivable, is called penumbra.
Sir. And pulsatility index in TCD.
Yes, sir.
అది రేడియాలజిస్ట్ బెటర్ హాఫ్ చెప్తారు.
So good morning, sir.
చెప్పాను కదా.
So pulsatility index means when you are doing the pulse wave Doppler, continuous wave Doppler, we can see the systolic velocity, like echo ejection fraction, how to measure, like the systolic velocity minus diastolic velocity by mean. So how much is coming? So that one we have to, one formula is there, sir. I forgot that one.
ఇప్పుడు చెప్పిన వాళ్ళ ఫార్ములా సిస్టాటిక్ వెలాసిటీ మైనస్ డయాస్టాలిక్ వెలాసిటీ బై మీన్ ఆర్టిరియల్ అంటున్నావు కదా.
That value have one formula, sir.
Okay, formula forget, madam. That is helpful for measuring what?
Yeah, ICP, raised ICP, we can measure that one. It is the one of the.
Is it ICP or CPP, Raman Prasad garu?
ICP,
sir. It is a surrogate marker of ICP.
Surrogate marker of intracranial pressure.
Yes, sir.
Okay.
Among evoked potential, which is commonly used?
SSCP kada sir?
SSCP is
sir. Brainstem auditory output potential.
Auditory output potential.
It is also used to, apart from bispectral index, brainstem auditory output potential is also used to measure the depth of anesthesia.
AEP.
Yes, sir.
Okay. నిమ్హాన్స్ లో ఉన్నాయా సార్ అవి?
ఉన్నాయి సార్. అది న్యూరోఫిజియాలజీ వాళ్ళు వచ్చి పెడతారు సార్.
ఓకే.
EMG of facial nerve monitoring is used commonly in which operation?
ఇది కదా పెరోటిడ్ కదా, థైరాయిడ్ పెరోటిడ్ కదా, పెరోటిడ్ సర్జరీలో కదా సార్?
Vestibular schwannoma surgeries.
మేడం
ఏం సర్జరీస్? schwannoma.
CP angle tumors.
ఇవి facial nerve monitoring.
Facial nerve. అదే అడిగింది. You told it is an auditory schwannoma, but I think it is CP angle లో మేము చూసాం కామన్ గా యూజ్ చేస్తారు facial nerve.
Okay, sir. వేరే నేను చదివిన దాంట్లో అయితే ఇది వెస్టిబులర్ శ్వానమాలో మోస్ట్ కామన్ యూస్ ఉంది సార్. మేబీ ఐఎమ్ రాంగ్.
కాదమ్మా, ఏంటన్నారు మీరు? ఏం శ్వానమా?
వెస్టిబులర్ శ్వానమా సర్జరీస్ లో మోస్ట్ కామన్ అన్నట్టు.
అది కూడా సిపి యాంగిల్ లోనే వస్తుందేమో కదా. సిపి యాంగిల్ ఇస్ ఎ బ్రాడ్ టర్మ్, బట్ దిస్ ఈజ్ స్పెసిఫిక్.
సార్.
This EEG is also used in giving ECTs.
Yes,
modified,
sir. Yes.
Modified ECT is called. When you monitor EEG, it is called modified ECT.
అంతేనా? ఇంకేం తేడా లేదా? EEG మానిటర్ చేస్తే మోడిఫైడ్ చేశారు సార్.
అంటే apart from isolating the limb, you also monitor these waves among the EEG.
ఐసోలేటింగ్ ద లింబ్ అంటే ఏంటి సార్?
you have to know the seizure duration, how much, whether you are evoking seizure or not. If you give succinylcholine, we cannot know whether the seizure is due to succinylcholine or due to the stimulus, electrical stimulus. So you isolate the limb before giving the relaxant and observe the seizure.
Sir, adi manam when we are giving this and using anesthesia, appudu modified antam kada. And on top of that, we use EEG also.
Oh yeah.
Use of anesthesia, muscle relaxant, and EEG. Okay.
You told the jugular venous oximetry for global cerebral oxygenation. For regional cerebral oxygenation, what is the diagnosis equipment used?
Hello, sir.
Jugular venous oximetry is used for global cerebral oxygenation.
Yes, sir. Yes, sir.
Regional cerebral oxygenation, what is the test or equipment?
NIRS, sir.
Huh?
Near infrared spectroscopy.
NIRS,
cerebral microelectrode. I don't know. I think that one.
Okay.
Cerebral microelectrode, sir.
Near infrared spectroscopy also can be used in.
Near infrared also can be used.
Yes, sir.
I will verify and tell, sir. I am not sure. I will verify. Thank you, Chaitanya madam. Elaborative.
Thank you, sir. Thank you. Thank you, sir.
Please plan, Anuradha.
సార్ చెప్పండి.
అందరూ గ్రూప్ లో ఉన్నారు కాబట్టి ఒకసారి వంశీ కప్పులు చైతన్య కప్పులు పెట్టి ఇద్దరు కప్పుల్స్ పెట్టి తొందరగా పార్టీ పెట్టు.
Yes, sir.
ఓకే.
Thank you, Chaitanya. Thank you, Srikanth. Thank you, sir.
థ్యాంక్ యూ చైతన్య.
Thank you all. Thank you.
బాగుంది చైతన్య.
Thank you, sir.
థ్యాంక్ యూ శ్రీకాంత్.
Thank you, sir.